Welcome, everybody. My name is Dr. Gurtej Singh. I'm an interventional pain specialist in the Baltimore, Maryland suburbs, and I am honored to be joined by Dr. Doug Beall, an interventional radiologist in Oklahoma City. Thanks for joining me tonight. We're going to hear speaking on behalf of the Global Spine Initiative, an initiative that helps bring together the fields of spine surgery, interventional radiology, as well as interventional pain management. Our focus tonight is going to spend a few minutes talking about kyphoplasty. Sometimes it's called vertebral augmentation, but I think patients really know it as cement in the spine to fix my fracture. So thanks for joining tonight. Kind of going to kick it off. Doug, you've been doing vertebral augmentation for
Yep.
probably one of the most world-renowned specialists in the field. Give us some of your perspective in terms of, when a patient shows up, how you help them through the process.
The first vertebral augmentation procedure I did was in the mid 90s. And I learned it from a guy named John Mathis, where I did residency in Baltimore. You're familiar with that, Gurtej, I know. And whenever I went to see the lady the next day, she was dressed, ready to go, 6:30 in the morning, complaining that I was late and that that she needed to go and do things. And I asked her how much pain she had, and she said, "Well, I don't have any pain." I said, "No, no. How much back pain do you have?" She said, "Well, I don't have any." I said, "What I mean is, how much pain do you have from the fracture that we worked on yesterday?" She said, "No, you don't understand. I don't have any back pain at all." So, and then she asked me if she could leave, and I said, "Well, I don't know. I've got to go get Dr. Mathis." She said, "Well, what usually happens?" I said, "Well, this is the first one I've ever seen. I've never even heard of this procedure before." That was like circa 1994. I discharged her later and walked out of the room thinking, man, I've got to do that. It was a Lazarus procedure. It was unbelievable. As much as we would like to think that there's a well-defined, well-oiled referral pattern. There's a few small number of our colleagues that are really good at recognizing fractures and, fall from a standing height and thin Caucasian female, Northern European descent, age 79. I mean, it's what the diagnoses, the differential includes a fracture, or perhaps a fracture. But yet people, it's a pulled muscle or a disc herniation. I mean, like she's throwing a football on a frozen rope to her grandson streaking down the sidelines. I mean, it's the patients themselves that really have mastered the referral. I still think, I've been at this a long time, and I still think the word of mouth referral is still the
Yeah.
best. The acute onset of back pain, the really significant degree of debilitation. And I think if there's one area of improvement, it would be recognition and referral for treatment of the fracture. And then if there's a second area, I think it would be to treat the underlying osteoporosis that gave rise to that fracture after the patient has undergone vertebral augmentation, because that's really what, in the short term, the augmentation procedure stabilizes the spine and will get them up and out of bed and limit the comorbidities. And, this has a rate of mortality of between 8 and 9 times age match controls. I mean, people
Yeah.
don't die of fat embolized in the lungs. It's not like a high-speed motor vehicle accident. They die of deconditioning.
Yeah.
A few years ago, Kevin Ong and Josh Hurst, I did a big analysis of the Medicare claims database, 10 years, 32 million people, 2,077,000 fractures, and 90% of the mortality was pneumonia
Yes.
and deconditioning, blood clots to the lungs, pulmonary emboli. So I think just if we could do better and recognize when to prevent in the short term the morbidity and subsequent mortality of vertebral augmentation, then in the medium to long term, treat their underlying disorder to make what we've done better. I think that is really kind of hitting for the cycle, and we certainly are not there yet, unfortunately.
I certainly couldn't agree with you more, Doug. I mean, these patients who come in, the number one concern is trying to get them back to their previous baseline. And these are not otherwise young and healthy patients. So the difficulty is the longer we wait to treat, the longer it is that we can get them back to their previous baseline. The pneumonia, the CHF, the UTI, unfortunately, even maybe even a bed sore, right? These are the things that are actually going to take out grandma, grandpa, and we have to get to them sooner. I was going to introduce Dr. Rita Roy. She's CEO of the National Spine Health Foundation. Rita, we'll pull you into the conversation because this is perfect timing. We're trying to kind of reach out to patients and have them, understand what is a spine fracture, the procedure, cementing versus what we typically use called kyphoplasty. In your experience, as CEO of the National Spine Health Foundation, give us how we can help patients gain better access, get better information.
Thank you, Gurtej. I'm delighted to be here tonight and be part of this conversation. I think when it comes to vertebral compression fractures, there are a couple of areas that are confusing to patients and frankly to some providers as well. We've been doing a lot of information at spinehealth.org to push information out about vertebral fractures, what they are, who treats them, how to prevent them, and what to do about them. Oftentimes, vertebral fractures are not seen, right? They are underdiagnosed, they get misdiagnosed, and that happens a lot to people. So one of the things that we want to do is try to educate frontline healthcare providers, whether that's family practitioners, internal medicine, primary care providers, to look for those signs of vertebral compression fractures. It's loss of height, it's the bending forward and those things that can help identify the fractures that aren't causing overt back pain, right? So there's those symptoms. And then there's back pain that comes from vertebral fractures. And once a patient is told that they have a vertebral compression fracture, they don't realize that that actually is a diagnosis of osteoporosis. And that's something that we want to really sort of drive home is that if you have a fracture in your vertebra and a fracture that came from not a trauma or a car accident or something, you have osteoporosis. And so not only do you need to treat that compression fracture, you have to treat the osteoporosis. And why? Why do you have to treat the osteoporosis? Because if you have a vert fracture, you are 5 times more likely to have a catastrophic secondary fracture. And by catastrophic, we mean a fracture that can lead to shortening your lifespan. So it's really, really important that we pay attention to diagnosing the vert fractures, educating patients about what it means to get it treated, and then for you providers who are interventionalists or spine surgeons to figure out how to get these patients on their osteoporosis treatment because they now have a lifelong condition. And we need to think about osteoporosis the same way we think about high blood pressure. It's a silent disease until it isn't. And so it's something that you're going to need treatment for the rest of your life. And particularly as we get older. So I'll stop there because I could keep going. But it's diagnosing the vert fractures, figuring out who treats them, which provider do you go to for that treatment, and then what do you do after you get a treatment for the vert fracture. Those are sort of the components in there that I think patients really need to understand.
That's a perfect transition. I had a wonderful opportunity about 10 or 15 years ago to meet this guy in Oklahoma City. Do you know him? His name's Doug Beall. And he actually goes from stem to stern. So, Doug, could you help educate us? And we'll get back to more of the kyphoplasty stuff in a minute. But
Yeah.
in terms of treating the osteoporosis, you're an interventional radiologist. In our world, that just seems like that's way out of your wheelhouse.
Yeah.
How have you and your team been able to actually make it part of your treatment protocol?
Yeah, as a radiologist, I can barely spell the word medication, but
Right.
I learned early on. I mean, this is very vivid to me. This is right at the start of my career. We had this lady; she was 78 years old, and she came in fracture. We'd repair it, fracture, fix, fracture, fix, fracture, fix. And the fourth time in, I stopped, said, Ray, find out who makes Forteo, and this was 2003. Get them in, and we're not doing this. We're gonna figure out exactly what to do to prevent this cascade of fractures. And what Rita said is absolutely true. I mean, this is music to my ears because if you have one fracture, 5 times increased risk of another two, 12, 3 or more fractures, you're between 35 and 75 times more increase. It's not if, it's when you're going to have another fracture. Each one of these have a mortality risk. I mean, why in the world would you ever think about not fixing a painful fracture or not treating the underlying osteoporosis. This is a single thing. This ranks right up there with the ability to do angioplasty and stent placement of coronary arteries. This has life-saving capability. We talked about life-saving capability for osteoporosis treatment is huge. So Bolland did this meta-analysis of just anti-resorptives, not even the medications that we would use, the bone-building medication, stop the loss drugs, really preventative drugs. Found an 11% in a decrease in mortality, 11%. And then there was a back and forth in New England Journal editorial page. Should we even be doing placebo-controlled osteoporosis medication treatments? Because, the Helsinki doctrine, first do no harm. And you're talking about 11% reduction with the worst medications, with medications designed for prevention, not even treatment. And so, we're talking about a reduction in mortality for kyphoplasty of 55% compared with those that have non-surgical management, or the so-called conservative care in air quotes. And, it's 25% decrease with vertebroplasty. So I think this is something that we really, and we're not doing a good job at all. You look at something like a hip fracture there's 3 anabolic agents. One was approved in 2002, and then that was teriparatide or Forteo. Then it went 2016, I believe, for a baloperitide, and then romosozumab was approved in 2019. And it's been a long time that we've had anabolic agents. You look back at it, 2002, about 22% of the patients were treated for their underlying osteoporosis after hip fracture. You fast forward it to 2011, it's down to half that. You fast forward it to recently, and I saw a paper recently that only 3% of people were treated for the underlying disorders. Not only are we not getting better, we're in fact getting worse. And I'm going to take a little exception to something that was said earlier. I don't think the literature's confusing at all. I don't think it's confusing one bit. So what's confusing is how did the New England Journal articles say they said there were negative articles about vertebroplasty versus non-surgical management. I've heard this very recently. So first of all, it's not a negative article. It was equivocal. The second thing, it wasn't versus what we do typically, which is non-surgical management, conservative care. It was versus an active sham treatment. And, I always like to do this, and they were published in the New England Journal, and people still hang on to this. I think a lot of our primary care colleagues are focused on this. And if you talk to a room of a few hundred people, how many of you guys in the room have heard of these two, the sham versus vertebroplasty in New England? Everybody, hands go up. 80, 90% of the hands go up. Then you ask them, do you know of any other vertebroplasty versus sham articles that were done? Anybody know of one? Maybe 2 or 3 hands go up. Hardly anybody's heard of this. And we have 3 positive trials: Vapor, VOPE, and Vertas 5. And it's not like they were published in some arcane journal. Bill Clark's Vapor trial was published in this rare, little-known journal called The Lancet that has a huge impact factor, as high as the New England Journal. It just happens that bad news travels fast, and the contrarians focus on the bad news. And the good news is the Vapor and VOPE were with acute and subacute fractures. And Vertas 5, now hardly anybody ever talks about Vertas 5. This was with painful chronic vertebral fractures. It had significantly better pain and functional improvement with fractures older than 3 months old. And where's the discussion on that? Because for years, there's mountains of evidence for treating acute and subacute fractures, and there is evidence for treating chronic fractures. This is a level 1 trial, a sham-controlled, blinded level 1 trial, and we have significant results at 1 year for pain and quality of life, which is not a common measurement, but it was using the QLFO. So this, and plus, in addition to this, we've got the world's largest kyphoplasty as treated on label trial using Medicare criteria, the Evolve trial. We've got a registry of over 1,000 people with complete data sets of 732 patients that had a pain score, a median pain score at 6 months from an 8 to a 0, and a Roland Morris, huge reduction in Roland Morris that was stable and durable. Kyphoplasty registry now that parallels that out. We had an interim analysis on that. We've got Medicare claims data that says that 55% mortality reduction for kyphoplasty. The number needed to treat to save a life is 15. So for those of you guys out there listening to this, thank you. The treat, because statistically, for every 15 patients you treat, you're saving somebody's life. And there's
And
nothing really that good. I mean, the only thing I think is comparable to that is aspirating a stroke out of the MCA artery, saving somebody's life. I mean,
yeah,
and it's about the same. It's about the same NNT for treatment effect as a clot buster for acute MCA stroke. Can you imagine not giving somebody TPA in the golden hour where they're there and have hemiparalysis, and you say, well, everything's good to go, but let's treat them conservatively.
totally,
Let's not do anything. Let that stroke take its natural course, and we know what the natural course with vertebral fractures are because it's twice as common as a hip fracture. I mean, there's 1 million of these a year. It's not like we don't know what the natural course is. So I think it's a lot more clear, I think, the data. And there's more than just that. There's 250 articles that come out a year. It's the literature definitely is replete.
There's no question about it. And Doug, I love the passion that you always have with this specific procedure because, patients, obviously they come to me. I'm in an orthopedic practice. It's very simple to explain to them. If you fractured your arm, would you just let it dangle around or would you just sort of hold it in place, for 6 weeks? No, it just doesn't make any sense. And I think patients sometimes don't hear that from whether it's the ER or from their primary care specialist or even unfortunately from some of their friends. Because the second you say spine, somebody who that doesn't have a fracture that had some completely different spine issue says, "Oh, it was horrible, don't do it." And patients, unfortunately, don't know the difference. And I think I'm very
Yep.
hopeful that this episode here tonight really helps patients understand that spine fractures absolutely need to get treated. They need to get treated the sooner rather than later. And part of that is not just because it helps to save life, not just because we can then get them to their osteoporosis treatment faster, but in fact that many patients don't know for most insurances, there's a window in which we have to actually get the kyphoplasty done. And so it's just so sad to see patients wait, 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 wait. And then when they finally come 2 months later and they say, okay, I'm ready, they're like, we have 4 days to get this done before your insurance company doesn't let it happen. And, it's crushing in that way.
It's
So,
a very good point. I think patients are confused, and that's where we can come in. They're
yeah,
confused and they conflate. They say, "Oh, I don't want to have that back surgery."
right.
Well, I
Our
mean,
back surgery.
look, this is not a real surgery. Anything that you don't use a suture or staple to close is not a real surgery. And this is more like an injection than anything else. I mean, there's essentially no recovery. You might be sore for 2 or 3 days. That's about it. And, Paul was
If
talking earlier about surgical fixation. Surgical
yeah,
fixation from fracture is a completely different thing, typically used for traumatic fractures,
yes.
burst fractures, magral B and fractures and C-type fractures. And there's good standalone evidence that even for magral A3.1 to 3.3 fractures, you can use standalone intrabody implants. I mean, I did a paper with David Noriega a few years ago, and we followed him up 5 years with magral A dot whatever fractures treated by standalone spine jack. And we followed him out 5 years, pain, function, and quality of life significantly better the whole time, no change in spinal alignment. It was kind of a permanent type of benefit. And so this is something that I think we can help convince the patients that look, we're not talking about a fusion surgery. We're not talking about a scoliosis surgery. We're talking about putting cement or an implant plus cement into your vertebrae to stabilize it so you can actually get up and move around.
Best
The idea about the kind of capricious and arbitrary idea you have to wait 6 weeks. Why? Would you wait 6 weeks for a pilon fracture or a hip fracture,
nope,
subtrochanteric fracture? It's just
there
insanity. I don't know.
I think there's something really important there in what you've said, and Dr. Beall, and that is that while we are providers and we are in the spine care universe, patients are not, and they don't understand the range. They don't understand the spectrum of treatment options that are available. So understanding the difference between cement augmentation in my spine versus a spinal fusion or a deformity surgery, it's all the same as surgery on my back, right? And I think that that's one of the challenging things in terms of patient education is helping patients understand the range, right, of treatment options that are there and what those different options provide to you and what they do. And when it comes to vertebral fractures, there is a lot of confusion in the patient population about when is the right time for conservative therapy? How long do you wait for conservative therapy? And when is the right time for there to be an intervention, a surgical intervention? And that's something that is confusing. There's misinformation, there's scattered information that's out there. And that's something that we're here to do, is to help dispel myths and to
I've
provide
got
real.
I've got a good one to add on to that. So based on the registry data, we had a large registry, and this is special because number one, it's the world's largest. Number two, it has to do with Medicare treatment criteria. It took Noridian's jurisdictions E and F, the LCD. It took the treatment rules of the road for treating the patients. That's what we used. So it wasn't like, inclusion, exclusion bias. It wasn't, oh, the PI doesn't like this or likes that. No, it's Medicare's rules of the road. And then we measured in a subset of those patients, a random subset of those patients, we measured costs on it, and we measured timing. And this past year, Emmanuel Hussey was the primary author on this at June, and I published this paper. We called it the time to treatment paper. And essentially, I can just boil it down to its base. The sooner you treated the patient after the vertebral fracture, the better they did clinically, and the cheaper it was to the healthcare system overall. And it was fairly dramatic. We used an example in the paper is somebody that got treated, roughly 3 weeks later. The cost was, between $6,000 and $7,000. So another patient got in a fracture and was delayed 180 days, if you can imagine that. So, if plan A is rest analgesic bracing, you have to have a plan B. And so there were multiple visits to the ER. There was, 6 different MRIs. I mean, there were, visits to the clinic, another visit to the clinic. There's, a couple of braces thrown in there, and it ended up being more than 3 times as expensive. And the patient did about 70 to 80% as well, because if you take the chronic pain, and with anything, including fractures, the more chronicity you throw in there, the more spinal deformity you throw in there, the longer the vertebral fracture goes untreated, meaning to raise the vertebral body height back up, the more difficult it is, because, it's partially healed. And I hear this all the time too. Well, my doctor said it's been a month or six weeks or 2 months. My vertebral fracture is healed. I said, okay, well, why are you here? Do you hurt? Well, yeah, just like I did right after the vertebral fracture. And, well, if it were healed, it wouldn't hurt you. So it's just trying to inject some of the common sense in here. And that's what the time to treat article was really excellent, because it measured cost and it measured outcomes in terms of pain and function using the Roland Morris disability. The earlier you treat, the better the patients do, and the cheaper it is.
Rita, what I do, what I try to do for my patients is kind of give them a little bit of a guide, right? Like, they have a fracture. My goal and my advice to all those listening, on the podcast is, the sooner you can get to see somebody who states that their expertise is spine fractures, the better. Because I think there is some value, and not every patient wants to jump into a procedure right away. And I think that's fair. Everybody has that choice to make for their own healthcare. But I would offer them to say, look, why don't we, for the first, say, 2 to 3 weeks, let's give you a pain medication, let's give you a brace, let's see what happens and how well you can manage this. And, having them with a 2-week follow-up back in the office allows the patient to try something that is the least conservative. With all the data that's out there, folks like Dr. Beall, myself, even, Dr. Park, we know that they're going to be back. We know that they're not going to be fixed, and we know we're going to end up doing the cement. But it really allows a patient to sort of give that college try to say, okay, did doing something conservative help or not? And it typically doesn't. Fortunately, it might in some cases. And so great, the patient's doing great at 2 weeks, and off they go. And then you get them into that osteoporosis treatment. But waiting longer than a month, I think, is really where patients need to know that that's a critical cutoff time. If you're waiting more than a month to get to somebody who knows how to do a cement procedure, you're putting your healthcare in jeopardy. And that's where Dr. Beall, has quoted the data that is just, it's unquestionable. you're going to risk multiple different things, including potentially your longevity of life if you're waiting longer than a month or so to get in and to consider having this procedure done. So, just a little guideline that I think could be very helpful for patients.
Yeah, I think that's so helpful, Dr. Beall. Talking about those studies is it's so important to understand the evidence that helps drive decision making so that patients understand I'm not ready for a surgery. That sounds really scary. And then you've got guidance like give it 2 weeks and see if it's better. And then if it's not, a decision point again, kind of a roadmap in there. And the Millman Institute produced a very large study looking at Medicare, the impact of osteoporosis on Medicare beneficiaries state by state as they went through every state. We know that spinal fractures are the single most common type of fracture caused by osteoporosis, and that they are often not treated and not diagnosed. And so we want to diagnose those. We want to get treatment, not just for the fracture itself, but for the osteoporosis. So, I guess my question to the surgeons on this call, the interventional spine experts on this call, is how the if the vert fracture is treated with a cement procedure, with a vertebroplasty or kyphoplasty, how do we make sure that the osteoporosis gets treated after that? Because we know that 15% of patients with the first time fracture in their vertebrae will fracture again within a year. Within a year. So it is just so important that that treatment of the osteoporosis happens. How do we help patients get that treatment? You are interventionalists. You're not necessarily the providers that are on the front lines of medical management of the osteoporosis. So how do we help patients with that part of the
So
treatment?
I've been apostle on this for a long time. I understand and don't disagree with what you just said there, Rita, but what my opinion is if you have enough expertise to treat a fracture, you have enough expertise to treat osteoporosis, the underlying disorder that caused that fracture. And if you don't learn, pick it up, self-educate yourself. So I'm writing a book now, and the title of it is treating osteoporosis for patients after vertebral compression fractures. And this is going to be a short book. I have an abbreviated version of it that I'm going to publish out as a handbook. And I want people to just understand this. I mean, the people who treat, if the thing is, if a fracture is treated and they go to Gurtej Singh and he does a kyphoplasty at T12 and that patient comes back, how are you doing? I'm doing incredible. I mean, my back pain's gone. Typical response, right? And he says, we need to treat your osteoporosis. We need to put you on an anabolic agent. They're injectable. I want you to take it. And statistically, we're going to raise your bone mineral density 12% after 2 years. We're going to, decrease your fracture risk of 86%. I'm quoting the active trial, Paul Miller's active trial. And I mean, that's a pretty compelling thing. If you've got the daughter in the room, that poor lady has no chance. She's going to take that osteoporosis treatment, and statistically, you will improve her life enormously. We've tried lots of things. We've been involved in the Medicare LCD development that includes the recommendation for osteoporosis treatment. We've been involved in the UCLA RAND appropriateness methodology, and this is standardized methodology carrying all the specialties in the same room, 131 different options for this standard appropriateness methodology. That in there, that has a requirement for osteoporosis treatment. You need to refer them or do it yourself in terms of osteoporosis treatment. And so
Yeah.
this is something that is absolutely essential. And it just, I don't know, I kind of think eventually we're going to get over the hump, and we're going to, instead of getting worse and worse with treatment and something that is demonstrably life-saving and life-prolonging, not only vertebral augmentation, but you bet your body. I give you one example of a meta-analysis of aneurysm. There's much more than that. So both of these things are demonstrably life-saving and life-prolonging. And what's going to take down the lady that's 83 years old that I treated today? I told her, I said, look, we got to get you on something. And you're good 83, a little bit of hypertension, that's it. I mean, what's going to happen when you're 95 puttering around and you fall down? What's going to happen is it's a hip fracture. It's not, assuming no cancer, your cardiovascular health is great. I mean, that's overwhelmingly what takes people down and debilitates them. and it makes them dependent on friends and family, and that's not what anybody wants.
Right, that's right. And I'm so delighted to hear about your monograph that's coming out. We've created a lot of resources for providers at spinehealth.org on bone health optimization, vertebral compression fractures, and osteoporosis treatment for the spine experts. So please take a look at those free open
Yes.
access CME resources. They're at bonehub.org or spinehealth.org. You can find them there. It's just important to continue to push the message out, provide resource to support the professionals in order to better support the patients and keep pushing the message on osteoporosis. We have an aging population, so maybe we are doing better with the treatment, but the numbers are just getting bigger. I'm not
No,
sure.
I think we're doing better. We're just not. I'm never satisfied with until every last person gets treated. I'm not satisfied with it. But the
I'm with
osteoporosis has recommendations, and thanks for those sources for recommendations. I do want to highlight one thing though, in terms of treating patients with fractures. Kind of going back to our first part of the conversation, people are sometimes mystified by what to do. Look at there are standard recommendations using the appropriateness methodology that I mentioned, the UCLA ran, just like there are in a number of different conditions. They're based on clinical symptoms. We talk about when to brace, and sometimes you don't know. The bottom line from that, and it's Josh Hurst is the lead author. I'm the second author on this, and the bottom line for this is you treat them based on symptoms, not time. Time appears nowhere in the expert recommendations for treating patients with underlying fractures. Nowhere. It's all symptoms, and some of it's imaging. So you see a patient with severe pain and an obvious fracture on imaging. And then the other one is what happens over time, the continuum of time. Are they getting better? Are they getting worse? Or are they staying about the same? And there are 7 different things that you can look at and you can put together, and there's very high levels of recommendation between on what to do. And if people are confused, you can look at these and it sounds like, oh, there's 7 things. I'll never remember the 7. There's simple stuff. Is a fracture getting better, getting worse? Is the pain getting better? Is it getting worse? Can they walk? I mean, do they have severe functional debilitation? Yes or no? And it's
yeah.
not really confusing at all. And there's an app on AVOMD, AVOMD, that you can go on, you can download this app and it'll ask you a few questions. How's the patient doing? What do you see on the imaging? And it'll come up with an answer. The best treatment is vertebral augmentation, or the best treatment is non-surgical management, or it'll come out, it'll tell you with just a few simple questions based on the clinical scenario what to do, and these are based on the expert recommendations through using the appropriateness methodology, using well over 100 different examples. And so this is about as good of a guidance as you got the expert right over your shoulder or right on your phone telling you what to do. And that's really, really something good to have. The osteoporosis treatments absolutely use those recommendations. I mean, if a radiologist can learn it, anybody can learn this stuff. It's not.
So as we kind of come to the end here, with our time on the podcast tonight, I want to certainly give both of you just another moment to sort of make one last pitch, whether it's education for patients or another piece of information. Dr. Roy, you want to start us off? One last, something that a patient should take away from tonight's
Yeah, I think one thing to take away when it comes to vertebral compression fractures is that the signs and symptoms aren't always pain. And so that is why they go undiagnosed and unseen. And it's this silent disease, and it's a silent condition that's going to cause you long-term consequences if it is not identified and properly treated. So, we have to think about our total body wellness, particularly as we age and particularly as we think about osteoporosis. 10 million people in the United States have osteoporosis. 8 million are women, 2 million are men. So it does affect men as well. And the loss of height can be one of those signs that we don't think about. We just think, well, that's just the normal part of aging. You shrink. Not always, and not by measurable amounts that can be equated to an osteoporotic vertebral fracture. So I think it's just, let's raise awareness about this condition. We want people to live better longer. None of us are going to live forever, but the time that we have on this earth, we want it to be independent living, doing the things that we want to do as long as we can. And I think that's what we are all here as providers, as people committed to delivery of care. That's what we want to see and have happen for people.
Dr. Beall,
Yeah, I'm going
take
to
home
mix
message for our audience.
these topics a little bit. One of the things that I want to pull out of this is the mortality data. As I mentioned that earlier, 55% reduction. I mean, that's 5 times what the Beall report, but it doesn't minimize that. Data says, Edmonds' big analysis says, if you treat the fracture, you lengthen the productive lifespan by 2.2 to 7.3 years per patient. It's a huge amount. And I give talks and present the mortality data and present the effectiveness data. I mean, this is more effective than anything that we know. The reduction of pain in the vertebral augmentation registry was 6.7 point. I mean, that's twice some of the other really good therapies that we have, and this is very powerful. I talked about the Evolve trial, the largest kyphoplasty trial that was ever done. 5 primary endpoints, a bunch of secondary endpoints. It was positive, statistically significant using Medicare criteria, and all of the primary and all of the secondary criteria throughout the entire 1 year of the trial with multiple visits. I also like to show the decrease in vertebral fracture reduction. The most recent anabolic PTH analog has a vertebral fracture reduction of additional fractures of 86%. Relative risk reduction, which is enormous. I remember giving a talk one time, and one of the questions afterwards, I talked about this data, I showed this data, and the person gets up and he said, well, that's kind of cheating, don't you think? Well, what do you mean by that? He said, well, it's kind of cheating. You talked about how your site did better in terms of pain and functional improvement in the Evolve trial, but then, you showed that you always use this bone agent that reduces additional fractures, and then you mentioned it also improves the pain. Don't you think that's cheating a little bit? And I said, well, no. So the difference is you could do it too, you just don't. And so I want to use that as example, as a challenge for my colleagues out there and a friendly challenge to, come on, just let's try to improve your practice and improve your outcomes. And the single best thing you could do to improve your outcomes would be a see and treat machine that not only identifies and treats the fractures, but then prevents and improves the pain on the back end. I mean, that's a perfect scenario. And the single best thing you can do to improve your outcomes is that.
Very good. No, yeah, I want to certainly thank Dr. Roy and Dr. Beall for joining me tonight. On behalf of the Global Spine Initiative, I think the take-home message that I would offer our patients tonight is advocacy. Hopefully, you're able to understand just how critically important it is that if you have a spine fracture, you must get yourself to a specialist who knows how to do a kyphoplasty, vertebroplasty, or even a cement in the spine procedure. However, you need to articulate it to your doctors. Please come and try to find one of us, because at Global Spine Initiative, we want to make sure whether you're seeing a neurosurgeon, an orthopedic spine surgeon, an interventional radiologist, or an interventional pain specialist, the patient and their care come first. And so I hope you appreciated the passion that my colleagues and I have had tonight on this topic. We take care of thousands of patients just like you having spine fractures, and we want to make sure that you get treated quickly, safely, and then we can get you on to that osteoporosis treatment and help prevent disease so that, as Dr. Roy said, you've got more life and meaning in the quantity of life that you have left. So for that tonight,
Amen.
thank you so much again, Rita and Doug. It was a
Pleasure. Good to see everybody.
Thanks for having me. Bye-bye.